Hello, everyone. Thank you for joining us for our session, Back to Normal, Healthcare Trends and Innovations Post-Pandemic, presented by our special guest, Professor Miriam F. Weismann from Florida International University in collaboration with Ivy Exec. My name is Mariana. I'm part of the higher education team here at Ivy Exec, and I will be helping to moderate today's session. Before we begin, I have a few brief housekeeping items for our audience. First, all attendees are in listen-only mode. However, we do encourage you to engage in the session by asking questions, which you can do using the question box in your Zoom panel. And please make sure to use this feature for all the questions you may have for the presenter, while we also invite you to use the in-chat feature for sharing any thoughts you may have with the rest of the audience. We will also be having a formal Q&A session towards the end, so please feel free to send in your questions throughout the webinar. Additionally, we are recording today's session, so you can also look forward to receiving a copy of the recording via email in the coming days. And now I will pass it on to Angel Burgos, Executive Director of MBA Programs at Florida International University.
Thank you, Sandra. It's a pleasure to be here today and to introduce today's guest speaker. But briefly, I just want to talk a little bit about Florida International University and the Chapman Graduate School of Business. For those of you who may not know too much about us, we are the largest professional school. The College of Business is the largest professional school within Florida International University, and Florida International University is now the fourth largest university in the United States. We have over 57,000 students, and we are recognized for being a minority-serving institution. We are #1 in the country for awarding degrees to Hispanic students at both the bachelor's and the master's level. FIU Business has long been recognized as the business school of the Americas, and we are ranked #2 for international business by US News and World Report, and several of our master's degrees are also ranked in the top by US News, QS World Rankings, and America Economia. And I invite you to get to know our programs through our website and learn more about our accreditation and our rankings. Today, we're going to hear from the director of one of our flagship programs, the Healthcare MBA program. The Healthcare MBA program at FIU is designed specifically for healthcare professionals and executives who want to develop the business skills and the leadership expertise needed to play an active role in the rapidly changing healthcare environment. This program is accredited both by AACSB and CAHME and offers a unique curriculum that weaves healthcare topics into every business course. This program is 18-month, it's cohort-based, and there are 2 start options: a hybrid format in Brickell, downtown Miami, which is a combination of online and in-person, and a fully online option as well. Now I'd like to briefly introduce today's guest speaker, Miriam Weismann. She is at FIU. She is the director of the Healthcare MBA program and a clinical professor of business law and tax in the School of Accounting. She also teaches in the law school. I know you have her bio, but briefly, before Miriam entered academia, she practiced law for almost 30 years. Before entering academia, she was a capital partner at a national law firm. After serving as an assistant federal prosecutor in New York, she was later appointed to serve as United States Attorney for the Southern District of Illinois, having prosecuted organized crime and public corruption cases. Her current research at FIU focuses on healthcare policy and reform. And the topic of today's discussion is Back to Normal, Healthcare Trends and Innovations Post-Pandemic. It's my pleasure to introduce one of the most outstanding professors from FIU Business, Professor Miriam Weismann.
Thank you, Angel. I appreciate your kind words and that fine introduction. And it is a pleasure to meet with all of you today in this webinar experience. And I hope that you do take the opportunity to send your questions in so that when we get to the end of the program, we can have more of a dialogue and I can address some of your thoughts and observations. So welcome. Now, this webinar will provide insight into the continuing complexities of healthcare reimbursement during the pandemic and some of the challenges of improving patient satisfaction to stabilize your reimbursement as healthcare transitions into this post-pandemic economic environment. Now, it's interesting because history teaches us that the world is forever changed in the aftermath of a pandemic. Now, whether it was the plague of Justinian in the 6th century, the bubonic plague in the 14th century, SARS in 2003, or the Ebola outbreak in 2014, at some level, and depending upon who and how many were affected, the economic, political, and religious order of things changed permanently. In short, an uncontrollable public health crisis like a pandemic is a powerful change agent that redefines our societal views and, in many instances, challenges our ethical principles. I mean, consider several revelations from COVID. Well, we've uncovered racial disparities in treatment. Some states have responded to the demand for healthcare rationing by designing emergency response plans, having the possible effect of excluding the more vulnerable populations in this country from treatment. We have witnessed violent discord over vaccinations and mask mandates. Office buildings are emptying as people retreat to home offices and the isolation of working in a community of one. Socializing is gauged by the probability of, will we facilitate a super spreader event? And the classroom has become a feared place to send our children. In truth, we have, for the last almost 2 years, organized our lives around the fear of COVID. And not surprisingly, we're all wondering, when will it be over? And I think we can all agree, from a public health policy standpoint, there's not going to be a day when we wake up to the newspaper headlines finally proclaiming COVID is defeated. No, in many ways, the future of the virus has arrived. And like the bubonic plague, which still reported a handful of deaths in 2015, COVID is here to stay. So we're going to talk about the economic aftermath of COVID-19 on hospitals and health systems. Now, the economic aftermath of COVID for hospitals, accountable care organizations known as ACOs, and allied healthcare organizations has likewise been devastating. Now, the American Hospital Association conducted a study over the 4-month period of March through June of 2020. And just in that 4-month period, it estimated a total 4-month financial impact of in excess of $202 billion in losses for America's hospitals and health systems, or an average of about $51 billion per month. Now, in September of 2021, the American Hospital Association released yet a second report outlining how COVID-19 was expected to drive continued hospital losses throughout 2021. This report estimated that hospitals nationwide would lose an estimated $54 billion in net income over the course of the year, even taking into account the federal relief from the CARES Act, known as the Coronavirus Aid, Relief, and Economic Security Act, passed last year. Now, the latest analysis examining actual financial performance in the first and second quarters of 2021 And the projections for the remainder of 2021 show that more than a third of US hospitals will maintain negative operating margins through year's end. And this may be compounded by the uncertain trajectory of the Delta and Omicron variants in the United States, which now could result in even greater economic losses. So let's consider for a moment, what are some of the contributing factors to this economic malaise? Well, one of the most common for hospitals, of course, was the postponement of elective surgeries early in the pandemic. And, this basically torpedoed hospital incomes. And according to the American College of Hospital Surgeons, it was a true economic disaster. Now, that AHA 2020 study I referred to just a moment ago estimated that non-treatment costs for hospitals and health systems was about $2.4 billion over that period of 4 months, just from March to June of 2020, or roughly about $600 million per month. Now, let me consider with you another example just to illustrate the point. A University of Pennsylvania study found that the suspension of elective surgeries from mid-March to July 2020, roughly the same 4-month period of the AHA study, cost one healthcare system in Philadelphia 42% of its net revenue at a loss of about $637,000 a month. Okay, but in addition to the postponement of elective surgery, hospital economic losses were compounded by 3 additional contributing factors. First, of course, patients were sicker. And studies show that hospitals are seeing more high acuity inpatient cases, including COVID-19 patients, requiring longer lengths of stay than prior to the pandemic in 2019. And while these cases are contributing to revenue increases, that's true, the economic gains are found to be offset by higher care costs for treating patients with much more severe conditions. And that, of course, leads into the very next point, higher costs. Expenses are rising across the board as hospitals face increasing costs for labor, drugs, purchased services, PPE, other medical and safety supplies needed to care for this group of higher acuity patients. Let me give you for example. The AHA estimated that the cost of support for frontline hospital workers in COVID-19 hotspots was about $2.2 billion in that 4-month period from March to June of 2020. That's about $550 million a month. And finally, what else contributes? Fewer outpatient visits. Hospital outpatient visits, which tend to have lower expenses and higher margins, continue to grow, but they still remain depressed compared to 2019 levels. In fact, they have yet to fully recover after plummeting with nationwide shutdowns and COVID-19 mitigation efforts in the very early months of the pandemic in 2020. All of which raises the question regarding which COVID precautions, if any, should end. Should they end now or soon? And which ones should become permanent? And more importantly, what are the lessons that healthcare policymakers and professionals should learn from this public health crisis? And we ask this question because of some really harsh criticism from health policy analysts such as Joseph Allen of Harvard, who observed that, quote, "We're sleepwalking into policy because we're not setting goals," unquote. Indeed, most healthcare providers agree that a national response to the pandemic has been needed since the outbreak, and it continues to remain sorely absent. I think we will agree that politicizing a public health crisis is in fact no policy at all, regardless of the merits of either side of that debate. Now, healthcare insurance and payment in the United States is highly fragmented. America's multi-payer system really spans an array of entities, including, as you can see from the slide, publicly financed programs like Medicare, Medicaid, and the military, which is TriStar, and commercial insurers and employer-provided health plans. And those, of course, really encompass the majority of insured Americans today. Now, interestingly, this particular slide will provide an overview of the different types of payers and populations in the United States. The value-based purchasing mantra of improving quality of healthcare, maintaining cost, and increasing patient satisfaction to maximize provider reimbursement truly remains a vexing challenge, both during and post-pandemic, as we watch our healthcare organizations endeavor to pick up these economic pieces left behind by the crisis. And it's not over yet. Now, since the passage of the Affordable Care Act, payment reimbursement initiatives were designed specifically to link provider reimbursement to value and quality of care under a system known as value-based purchasing, VBP. So here in these models, value includes both cost and the quality of care. So the VBP model should be distinguished from the fee-for-service reimbursement model. And that model is based on the volume of services provided. You get paid for how many services you provide. Now, what's the reality of which model prevails in the marketplace? Well, the reality is that fee-for-service reimbursement still dominates in the healthcare industry, with roughly 40% of healthcare payments made in 2018, which was pre-pandemic, under fee-for-service. And this was according to the Healthcare Payment Learning and Action Network, the LAN network. But it's also important to recognize that pre-pandemic, there was a positive movement towards value-based purchasing models. And in fact, 1 in 3 healthcare payments did flow through some sort of value-based alternative payment model. Now, the movement at that time was projected to continue to grow. But with the emergence of COVID, this course reversed itself. And those reasons it reversed itself are tied to certain financial risks that are attendant to the VBP model. A recent study conducted by the National Association of ACOs in 2020 reported that clinicians in value-based payment arrangements could expect to face higher levels of financial risk than their fee-for-service counterparts. Now, this study, interestingly, was collected, the data was collected from 220 ACOs nationwide. Now, why am I talking about this study about ACOs? What makes it important here? Well, let's look at some of the legislative history of the Affordable Care Act. The Affordable Care Act officially introduced ACOs to support the healthcare industry's overarching goal of achieving triple aim. And those of us in the healthcare field understand the importance of triple aim. Triple aim means to improve care quality, enhance the patient experience, and decrease healthcare costs. And since the ACA, the Affordable Care Act, providers and payers have formed over 1,000 ACOs covering about 32.7 million patients across the country. And those numbers were predicted to increase as value-based participation was supposed to eclipse fee for service. Now, what's an ACO? What's an accountable care organization? Real quickly, an ACO is a group of hospitals, physicians, or other providers who agree to come together and coordinate their care for patients and deliver the right care at the right time while avoiding unnecessary utilization of services and medical record errors that were historically attendant to fee for service. But here's where the financial risk comes in. ACO participants also agree to take on responsibility for the total costs of care for their patients. ACOs that reduce the total cost of care, well, they can share in what's called shared savings with the payer. But in certain models, they may also be liable to pay back losses if their costs exceed the spending benchmarks in their programs. Policymakers and healthcare leaders actually believed initially that tying financial incentives to care quality, patient outcomes, and care coordination through ACOs was a key solution to fix the inefficient fee-for-service system. In short, ACOs were seen to be a major player in the value-based care and payment transformation. But what we found as a result of this ACO study in 2020 was that 90% of those surveyed reported that they feared the pandemic would have a significant or very significant effect on the ability to earn revenues from shared savings. Now, why is this survey data of great importance? Well, it has everything to do with revenues and losses, because the unreimbursed operating costs are referred to as sunk costs. So let's look at how this works for ACOs. Shared saving payments for ACOs are often the only funding they have to keep themselves functioning. Those revenues are what keeps them going. So Medicare does not pay ACOs a per member, per month, or per year payment, nor does it provide additional support to fund ACO operating costs, these sunk costs that go towards additional clinical resources, data analytics, care coordinators, health IT, compliance, or administration. Now, a sunk cost is money that's been spent and can't be recovered. So in addition to sunk costs, it was expected that these providers would face reductions in reimbursement at year end when both their increased spending due to higher acuity patients and their performance metrics based on the chaos created by the pandemic were evaluated. As a result, almost 60% of the ACOs surveyed reported that they were likely to drop out of a value-based purchasing risk-based model to avoid having to repay the losses for 2020 resulting from these unforeseen operations during the pandemic. Some 77% of survey respondents were very concerned about the coronavirus's impact on their 2020 economic performance. Now, it's fair to say that there has been universal agreement among providers and CMS, the regulator, that COVID-19 has upended normal utilization and care patterns. It has disrupted ACO's ability to employ successful population health strategies and has caused tremendous uncertainty about benchmarking costs. There is also notable uncertainty on how the pandemic will affect other aspects of the ACO programs, such as changes to acuity or risk scores, diminished opportunities to meet quality requirements related to preventative care, and which patients the ACO is even going to be accountable for in both 2021 and 2022. And all of these unknowns led the National Association of ACOs CEO, Cliff Goss, in a letter to CMS conclude that, quote, the value-based movement is at a critical juncture, unquote. The ACO survey, these results paint a potentially grim picture for ACOs and the industry move toward value-based purchasing. Now, advancing to value-based care has been a priority of Congress and the regulators. And it's fair to say that if the Department of Health and Human Services goal remains moving all Medicare payments into these alternative value-based purchasing models by 2025, then arguably from a policy standpoint, it's going to be imperative for the government to adapt its models and its supporting data metrics used to measure to withstand highly unusual circumstances that are brought on by COVID-19. And interestingly, the National Association of ACOs and other leading healthcare organizations are calling on Congress currently to cancel repayment of all ACO losses for performance year 2020. We'll have to see how that shakes out. The bottom line is that there is universal agreement that pre-COVID value-based purchasing models are simply not designed to facilitate COVID and post-COVID reimbursement determinations using the same metrics. So before we get to some of the regulatory solutions, let's consider the current models that arguably are going to require this legislative adaptation presented by the challenges of COVID. Now, among the four types of value-based arrangements are shared risk, global capitation, bundled care, and shared savings. So let's just look at these briefly. What's a shared risk model? Well, here, the parties agree on clinical and economic outcomes that are historically measured. So they do these measurements historically. They agree on what the outcomes should be prior to signing their contract. And then future payment is dependent on meeting these agreed upon measures by the parties. Global capitation pays a fixed amount to providers based on the number of patients they see or the number of patients that they have. Bundled care is a method of reimbursement in which a single comprehensive payment is made for a separate episode of care. The idea is that if you bundle a bunch of services into a solitary episode of care, you reduce costs and increase efficiency. Finally, with shared savings, this is a payment strategy that offers incentives for provider entities to reduce their healthcare spending by looking at defined patient populations and offering the provider a percentage of any net savings realized as a result of their efforts with that particular patient population. It's a real experiment in population health. But what is true of all of these models is that they typically require an upfront financial commitment by the provider. And the concern here, of course, is that providers aren't likely to put much more capital at risk given the current economic situation. Providers will instead focus on making up the losses they sustained during the pandemic by, of course, ramping up capacity and charging again based on a fee-for-service model. But it is important to point out that the financial challenges brought on by the pandemic are not only confined to value-based purchasing models. I mean, frankly, the fee-for-service model is no panacea. Dan Bowles, who's the Senior Vice President of the Growth and Network Operations at the ACO Aldade, stated that, quote, "If all of your revenue is based on patients walking in the door, when they can't walk in the door anymore, you're kind of up the creek without a paddle. You need to find a way to create non-visit-based revenue," unquote. And that non-visit based revenue doesn't shift our course back to value-based purchasing. Instead, what we've seen is a push toward developing telehealth visits, non-visit based revenue. Now, early in COVID-19, telehealth usage surged as customers and consumers and providers sought, what is a healthy and safe way to deliver healthcare? So interestingly, in April of 2020, over telehealth utilization for office visits and outpatient care was 78 times higher than it was in February of 2020, a pretty quick escalation. Now, some regulatory changes that enabled greater telehealth access have been made permanent as a result of COVID-19. Give you 4 examples. In 2021, CMS made telehealth coverage for a number of CPT codes, current procedural terminology codes, permanent under the physician fee scheduling final rules. However, we can't get too carried away because this area remains fraught with uncertainty, as other restrictions on telehealth reimbursement may return to pre-COVID-19 normal whenever this public health emergency expires. So we're just going to have to stay tuned. Let's look at some of the numbers on annual revenues. Pre-COVID-19, the total annual revenues of U.S. telehealth providers was about an estimated $3 billion. And the largest vendors were focused in the virtual urgent care segment. The virtual urgent care segment helps consumers get on-demand, instant telehealth visits with physicians. Now, most likely, this is a physician they have no prior relationship with, but it does work for, in particular, primary care. With the acceleration of consumer and provider adoption of telehealth and the extension of telehealth services beyond virtual urgent care, it's predicted that up to $250 billion of current U.S. healthcare spending could potentially be virtualized going forward. But regardless of which delivery modality is eventually utilized, measuring quality of care under a value-based purchasing system during a pandemic is extremely problematic. Most of CMS's value-based purchasing programs, such as the Hospital Value-Based Purchasing Program, the Hospital Readmissions Reduction Program, and the Hospital Acquired Condition, the HAC Reduction Program, all rely on retrospective data to evaluate quality. And from this chart, you can see that quality impacts during COVID-19 will affect Medicare reimbursement to providers through 2024 for most programs, and you can see in some cases through 2025. Now, in a recent article in Health Affairs, the authors again emphasize that the current hospital quality programs and measures, which include HCAHME patient satisfaction surveys designed to measure patient satisfaction, are not designed to contend with pandemics or public health emergencies of the magnitude that we're experiencing, nor are they equipped to manage the degree of aberration being encountered in these underlying data plans. And this is very important when it comes to calculating reimbursement. So let's consider several of the factors that create this aberration in quality data measurement during the pandemic. We start with data reporting quality. Now, the regulator CMS has recognized that quality measure data collection and reporting for services furnished during the pandemic really may not reflect a provider's true level of performance on measures such as cost, readmissions, and patient experience. For instance, the data could show a drop in the quality during COVID-19, but not actually due to worse quality, but simply due to complications in reporting the data. Okay, so CMS has provided some temporary relief during the time of emergency. It will hold organization harmless for not submitting any quality data during a certain period. And these are called reporting exceptions. And we're going to cover reporting exceptions under CMS in just a moment. Now, the second aberration I want to talk with is dealing with COVID quality measures. Prior to 2020, and this is kind of remarkable, there were no quality measures related to the quality of providing COVID care. So even if a hospital provided great COVID-19 care, they don't get any credit for that under the existing value-based purchasing systems because there's no measure to quantify this dimension of quality. And further, there were new challenges that hospitals and other providers had to deal with, including additional costs for PPEs, infection control protocols. And one very interesting study has found that the rates of readmission or death, which are negative reimbursement metrics, were higher during the first 10 days after discharge following COVID-19 hospitalization, which does suggest a period of heightened risk of clinical deterioration. And that's not surprising, given that COVID patients often have an extended length of stay due to inability to transfer or higher patient acuity. But this will automatically impact measures regarding spending per Medicare beneficiary. They're going to be much higher. And added to this confusion was the implementation of necessary strict visitor restrictions to limit viral spread. Well, we know the impact that disrupted family visitation is going to have. That will invariably affect measures of patient experience. It can exacerbate patient delirium and contribute to higher fall rates. Now, what about capacity constraints? Well, with so much effort used to deal with COVID, there was less space available and less staff available to treat patients who have other diseases. So in terms of measuring patient satisfaction, which is a key metric in value-based purchasing for purposes of reimbursement, we know that staffing is a very critical component in the HCAHME and other patient satisfaction surveys. Now, staffing shortages have been a growing concern for the entire healthcare sector nationwide. Even before COVID-19, we have a looming forecast of a national deficit of the healthcare workforce by 2025. COVID, of course, is added to the strain, requiring hospitals to ramp up their staff for surges, and facilities faced workforce challenges as healthcare workers also fell sick or needed to quarantine after they were exposed to COVID. In addition, we, of course, from an economic standpoint, have reports of anti-competitive pricing by nurse staffing agencies during a time when hospitals have been in desperate need of caregivers, which further exacerbates staffing shortages in rural, smaller, and urban public hospitals. And these challenges have impacted Health Association infection rates, the HAI number, patient experience, efficiency, and cost reduction. What about case mix during COVID? Well, during the peaks of the pandemic, we find individuals did their best to avoid going to the hospital. So obviously, most people who went to the hospital were those who had no other choice. And not surprisingly then, the acuity of non-COVID patients admitted to hospitals during the pandemic is going to be much more severe than normal because they have to be there. Otherwise, they wouldn't be there. And what about the case mix after COVID? Well, the case mix of patients after COVID may also be more severe because a lot of individuals have had to put off getting preventive or maintenance care. Others have had to put off needed surgeries. So patients after the pandemic may also present with more acuity due to decisions to put off needed care. And to further complicate matters, COVID-19's impact on quality measurement is subject to at least 4 additional variables. First, geographic variation in the spread of COVID, temporal variation in the spread of COVID, variation in acuity of COVID-19 impact across various populations, and variation in acuity of COVID influx, all of which affected hospitals differently in 2020 and 2021. In other words, and this is important, there is as yet no one-size-fits-all adjustments to reimbursement that accounts for the pandemic's impact on each and every hospital. Now, as I mentioned a moment ago, CMS did fashion a regulatory response designed to provide at least temporary relief to address this data reporting situation. In March 2020, CMS announced that it would grant exceptions from reporting requirements and extensions for clinicians and providers participating in Medicare quality reporting programs with respect to measure reporting and data submission for these programs. The exceptions provide that those programs that had data submission deadlines in April and May of 2020 could choose not to submit the data. The data submission would be optional based on the facility's choice to report. And in addition, no data reflecting services provided from January 1st of 2020 through June 30th of 2020 will be used in CMS's calculations for the Medicare quality reporting and value-based purchasing program. So this is very important. Now, this is being done to reduce data collection and the reporting burden on providers. So this is called an extraordinary circumstances exception. And if you are a hospital or allied healthcare agency and you're adversely impacted by the extraordinary circumstance of the pandemic, you can request CMS for the hospital value-based purchasing program and the HAC reduction program within 90 days of the date of the extraordinary circumstance, a waiver from reporting your data. Now, here's the consequence of doing that. A granted ECE in the hospital value-based purchasing program will exclude the hospital from the value-based purchasing program in the fiscal year in which its performance is impacted. So the good news is the excluded hospital doesn't incur a 2% payment reduction, but the bad news is it also will not receive incentive payments for that fiscal year, and there's no reward metric in place for rewarding those hospitals that gave spectacular service during the pandemic. Now, we still don't know with any real degree of precision how and to what extent COVID-19 has introduced uncertainty into the process of assessing hospital performance on these various quality measures. One thing we do know is that the uncertainty continues to exist. And while the full economic impact of COVID-19 on hospitals and health systems is yet to be understood, understanding the specific impact and predicting effects on data can help us direct our analysis and avoid penalizing hospitals and provider reimbursement for delivering what's otherwise extraordinary care during a period of extraordinary crisis. And I really want to thank all of you for your attention and for attending, and open it up now for your questions.
Thank you so much, Miriam. This was very insightful presentation. We do have a couple of questions ready for you. So here's the first one. Did COVID-19 help set a path to improved healthcare efficiency?
Well, the answer is maybe. At this point, hospitals continue to be inundated by changing patterns of care of patients. And certainly when hospitals are overcome with patients, in other words, they have limited space, they have limited staff, and they're completely overwhelmed, and they have no place to transfer the patients, efficiency suffers. There's no question about it. However, the data that we are collecting from this experience, I believe, will ultimately help us formulate future policies and best practices that will be designed to improve efficiency. So I think it's just a question of when we're going to be able to take a deep breath, look at the data, and calculate best practices. But I think it will be a future result.
Wonderful, thank you. Here's another question coming from Marissa. Based on all the data you've shared and your own expertise, what are your personal predictions for the healthcare industry over the next 10 years? Which models of care do you predict will be dominant?
Well, here's an it depends. It depends on what CMS is willing to do, for example, with new modalities of delivery. In other words, are we going to make many of the temporary telehealth expenditures permanent? If we can have a more vibrant telehealth system of healthcare in the United States. I travel with our students all over the world, and we study other healthcare systems. And one thing I can tell you, particularly from developed countries in Western Europe, the telehealth systems there are light years advanced past what's in the United States. And if we can quantify and virtualize reimbursement for telehealth, I think that we're going to have a very robust healthcare economy. The biggest problem, though, is healthcare reform and reimbursement. And right now, our metrics are not suitable to deal with the healthcare system we've had for the last 2 years. And unfortunately, it is Congress that creates the reimbursement legislation, which is then facilitated by regulations by CMS. And until Congress stops politicizing healthcare policy and really considers what is in the best interests of a nation's healthcare policy, we are going to continue to experience cost overrides. And we're going to be chipping away at trying to deal with efficiency, patient satisfaction, and cost reduction, because we really do not have any efficient policies, including value-based purchasing, to achieve the real goals. I mean, consider that 17%, maybe 18% now of our gross domestic product is healthcare expenditures. It's enormous. And those kinds of numbers aren't going to be fixed with this piecemeal approach. And of course, the other problem is that, you have organizations like the American Medical Association and others that have a lot of clout in Congress and don't want to change our current policies to have real reduction in spending. So, there's a lot of politics involved here, and it's very problematic.
Thank you, Professor Weismann. Here's another question. What can students do to help lead positive change in the changing healthcare landscape? That's one of the questions coming from Kyla.
Kyla, that's an outstanding question. One of the things, for example, that we do in our Healthcare MBA program is we focus on healthcare policy. You know, there are some programs that are only quantitative. Ours is certainly quantitative, but you have to develop students who think about policy, who start thinking about efficiencies and taking what is otherwise quantitative data and interpreting it into what is the quality of care? How do we take what we're spending and what we're making in terms of revenues and create a healthcare quality policy, a best practices policy to rein in costs and, you know, follow triple aim. You know, how do we rein in costs, improve the delivery of healthcare, and increase patient satisfaction? That is an exercise in healthcare policy. And you have to be in a program as a student that is really focused on developing policy makers in the next decades, because those policy makers are going to be critical to our success. So students should be really focusing on health policy changes in the marketplace. What works?
Excellent. Thank you. Here's another question coming from Allison. We've been talking about hospital care, but what we're struggling with is the increased cost of products and also low supply. Does that not affect patient care and how we are planning to handle supply chain?
A brilliant question. I mean, that's a whole nother webinar for another day. Without a doubt, the costs of products have skyrocketed. We've lost control of our ability to monitor these costs, particularly in pharmaceutical costs. We've seen skyrocketing, but it's, you know, even with PPE, you know, I think I said during the webinar, you're looking at, you know, $50 million a month just to clothe and care for your frontline healthcare, you know, providers. So unless we can capture these healthcare costs and get them under control, I mean, look, Medicare, because Congress, you know, is looking at who their political contributors are, Medicare doesn't even have the power to negotiate its pharmaceutical rates. That's ridiculous, right? But again, Congress goes to the pharmaceutical industries who are making very substantial campaign contributions, and they're not going to rock that boat, right? Even though it could result in tremendous cost savings for Medicare and Medicaid. They won't do it. They won't allow them to negotiate their rates. I mean, things like that have to change, and those are political changes, unfortunately. We have non-healthcare experts dictating expert healthcare policy. Doesn't work. And it's a tragedy in the system. So your point is very well taken.
Thank you. Here's another question. Do you know what are the health insurance company strategies to address ongoing changes? What areas they plan to focus on the most?
Well, you can be sure that they're talking to Congress about this now. I mean, health insurance companies obviously try to increase their profitability, and they do that by one thing and one thing only, which is not paying claims. That's really part and parcel of how they govern their revenues. And the pandemic has taken some of that ability away, but you can be sure that the health insurance industry is looking forward to the end of the pandemic. They are looking to getting out of value-based purchasing because it has increased their sunk costs and risks. And they are really meeting with Congress right now to make sure that they protect their own economic interests. So again, you know, it's a very political question, very political.
Thank you. What can healthcare stakeholders do to make health more equitable?
Well, the first thing is to recognize where the inequities exist. And I just published an article in the American Journal of Law and Medicine It's in volume 47 for 2021. The name of the article is called Ruthless Utilitarianism. COVID-19 state triage protocols may subject patients to racial discrimination and providers to legal liability. Providers really need to look at how current metrics are resulting in promoting certain healthier patients above those who have comorbidities that make their own survival less likely, because it tends to focus on racial discrimination, right? Consider this. I mean, we have minorities who don't receive the same health care, either because they don't qualify for health insurance or because under the marketplace, their insurance is limited. And so they don't get the same health care that someone gets from their employer provided plan. And so these minorities who also live in health deserts, who can't control their diets, it increases comorbidities. And those comorbidities, when you have a pandemic, increases the lack of survival rates. And when we do healthcare rationing, we use these very cold metrics and we say, well, if you're less likely to survive, we're going to give the medication to those patients who can survive. And the metrics fail to take into the context that minorities are there because they don't have equal access to care. So we're really penalizing minorities twice. First, by not giving them equal access to care, which creates higher health problems, higher comorbidities. And then when it's their time to share in the cure, we're going to penalize them again because we're going to give the cures to people who have a better chance of survival because they have better access to health care. So before we can really begin to focus on health equity, we have to really be honest about the current metric systems that we're using in healthcare and really uncover where the inequities exist. Once we know where those inequities exist, we can move forward to fix the problem. But we have to face the truth about what is happening in healthcare today.
Thank you, Professor Weismann. I believe we have time for one more question. Can you tell us a little bit more about the key elements of the use of different reimbursement methods?
Well, if we look at fee for service, okay, what providers typically did in the past was they would provide a service, the service had a reimbursement fee, and they would get paid for that. And the downside of that, of course, is that there's an incentive. What's the incentive? Well, if I'm a provider and I provide more services, I make more money. It's as simple as that. So what the healthcare system has tried to do is get away from a reimbursement system that incentivizes providers to give as much treatment as they can, whether it's necessary or not, to maximize the fee for service they receive. How do we do that? Well, we move to value-based purchasing and we say, look, we will give you a higher rate of reimbursement to the extent you reduce your costs. The way you reduce your costs is to have wellness programs to prevent excessive healthcare costs going forward. In other words, preventative medicine, rather than simply giving a patient as many procedures as you can. And if you can figure out a way to create wellness and preventive medicine and decrease your costs, then we'll increase your reimbursement. And that's the incentive for value-based purchasing. You can see the difference between the two.
Perfect. Well, thank you so much, Professor Weismann. We truly appreciate the opportunity to have you present for Ivy Exec audience. Thanks so much for this wonderful presentation. And I would also like to thank all of you for joining us today. We will definitely make sure to share the recording of the webinar in the coming days. But till then, I wish you all a great rest of your day. Take care.
Thank you.
Thank you so much. Bye.